Welcome to Why Do We Need to Elevate the S in SBC to Improve Family Planning and Reproductive Health Outcomes. It's my pleasure to invite you all to what is going to be a very enthusiastic and rich discussion. Next slide, please. So a quick run of show for today. Of course, I've opened up with our welcome and housekeeping, and I'm very excited to turn it over shortly to my colleague, Lynn Van Lith, Technical Director, who will provide us with an introduction and overview regarding today's event. We'll then transition into our main feature for today's event, which will be a panel discussion. This panel discussion will be moderated by Dr. Carol Underwood, and our illustrious panelists today are featured here and will be introduced later on by Dr. Underwood herself. Without further ado, I'd like to turn over to my colleague, Lynn Van Lith. Lynn, thank you so much. And next slide, please.
Great. Thanks, Danette, and welcome again to all of you. If we move to the next slide, I will speak just very briefly before handing over to our panelists, and wanted to first introduce the Breakthrough Action Project for those of you who may not be familiar with it. We are a cooperative agreement funded by USAID, led by Johns Hopkins Center for Communication Programs in collaboration with Save the Children, Think Place, Ideas 42, Canberra Collective, ICRW, and VIAMO. So on the next slide, you'll see just a snapshot. We have worked in 42 countries and are currently operating in 26. And on the next slide, I want to start with just a few key definitions that we have been thinking about and using as we have embarked on this work. The first is drawn from Healthy People 2030, and it is the definition of social determinants of health, which are conditions in environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Health equity, as defined by WHO, is the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. Let's move to the next slide. I want to share just two models. This work through WHO Commission on the Social Determinants of Health started back in 2005. We are certainly not the first people to be thinking about this, but really want to build on the conceptual frameworks that are available and that where so much thought has already gone into this. So if we look, and again, this is a busy slide, but just want to draw your attention to starting on the left, the social and political context. Moving to the center, really looking at social hierarchy and the issue of power and class, and really who has access to resources and makes decisions, and leading over to the social determinants of health and the true impact that all of these dimensions, these factors have on health outcomes. So on the next slide, we also want to highlight this framework, which is quite comprehensive and really simple to follow, again, from Healthy People 2030. The definition here breaks down the social determinants of health across these 5 different domains, again, focused on economic stability, education, healthcare access and quality, neighborhood and built environment, social and community context. And the real takeaway here is that social determinants of health are shaped by distribution of power and in many cases lead to unfair differences in health status. So we want to keep these definitions in mind as we move to the next slide and start thinking about the intersection with social and behavior change. In defining social and behavior change, it is a discipline drawn from the social and behavioral sciences that uses a deep understanding of human and societal behavior and evidence-based interventions to increase the adoption of healthy behaviors by both individuals as well as the influences, the social and structural factors that influence and underpin them. And that is a piece that is really important as we move to the next slide. I think some of us working in social and behavior change have perhaps overemphasized, in some cases, individual behavior change, when in fact, so much of individual behavior change is shaped by those social and structural factors, whether they're social norms, gender norms, or some of the more structural factors and policies that really contribute to intersectional marginalization and, again, inequitable health outcomes. So with all of these thoughts in mind, on the next slide, we embarked on a process of really taking a look at what was in the peer review literature related to the social determinants of health. And the key questions that we were concerned with was, well, three-part really. First, what do we know about using SBC approaches to address social determinants of health? And we really narrowed in on family planning and reproductive health for this exercise, though certainly the findings can be applied to any health and development area beyond family planning and reproductive health. The second question we asked and looked at in the literature was, what are some of the promising practices for addressing social determinants of health? And finally, what are some of the gaps in both research and programming? And where might more investment be needed to really focus in on the social determinants of health? So we were looking at this intersection of the role of social and behavior change programming and research, and how it might address some of the social determinants of health to improve more equitable outcomes. So we drafted a technical report and held an expert consultation, and we're at the point now of disseminating some of this work with you all today. But I want to just focus a bit here on the next slide around the expert consultation. This work was certainly not done in isolation, and we benefited greatly from the 25 experts you see here on the screen. They joined us from Cote d'Ivoire, from Mexico, Nigeria, Paraguay, the Philippines, Senegal, South Africa, Tanzania, the United Kingdom, and here in the United States. And the beauty of this diverse group is that we had people coming from ministries of health, from donor organizations, and from SBC practitioners. And you will see 3 of these experts on our panel today. We're very fortunate to have them with us. We also invited researchers who had published in the peer review literature to really ground us in the evidence base of what exists and what is known around the social determinants of health and the programming that might address it most effectively. So on the next slide, I just want to highlight from these consultations and from the literature review, we developed two materials. The first one here is really focused as a resource for governments and donors, sort of some higher level thinking around major considerations that they might consider when addressing the social determinants of health, and really thinking about the role that social and behavior change programming may play. So I won't go through all of them, and I think we're adding the link to this particular resource in the chat, and really invite you to take a look at it. There's quite a bit of detail in it, including more information on those models and frameworks that I presented earlier, or really just touched on. So the first key consideration, and I'll just highlight a couple in the interest of time, is around exploring long-term multi-sectoral and co-funded partnerships. Given the complexity of addressing social determinants of health, we know that none of us can do it alone. And one of the most important things we can do is partner and collaborate with others to address them wholly. Also, I want to highlight the second point around requiring absolutely meaningful partnership with communities to ensure that whatever takes place in terms of programmatic interventions is driven by community needs and values. So again, I won't go through all of these now, but really our panelists today will be speaking to and highlighting not only some of the elements that are in this document, but certainly their own thoughts given their experience in this space. So moving to the next and final slide I will share is a focus on the second tool that Breakthrough Action developed, again with the help of a technical advisory group. And in this case, we invited people, really SBC practitioners working across a variety of countries. So we developed this tool. It's really practical tool for how to really consider intentionally the social determinants of health within SBC programming. So you'll see the 5 elements listed on the slide here that are involved in this document. And it's really meant to be a living document. We've started pulling together some of the thinking, but there is certainly much more to be done. So in the interest of time, on the next slide, we just want to continue this conversation and really invite you to take a look at those 2 resources that were added in the chat. and want to hand over to our panelists who really will continue this conversation and have far more to say about this topic. So on the next slide, it is my absolute pleasure to introduce Dr. Carol Underwood. Not only has she been immersed in these issues for decades, she shares her time with the Center for Communication Programs and also teaches students at the Bloomberg School on these topics. So Carol, over to you for the introductions.
Thank you, Lynn and Danette, for the introduction and background. It's now my pleasure to introduce our distinguished panel members who have diverse experience in addressing the social determinants of health. Beverly Lorraine Ho is the Concurrent Director for the Health Promotion Bureau and the Disease Prevention and Control Bureau at the Department of Health in the Philippines. Immediately prior, she was Chief of the Research Division of the Health Policy Development and Planning Bureau, where her efforts significantly contributed to the passage of key legislation on factors that are very much related to the social determinants of health: social sweetened beverage tax, tobacco tax, and universal health care. She's also worked in the Philippine Health Insurance Corporation and the Asian Development Bank. She holds an MD from the University of the Philippines and an MPH in Health Policy and Management from the Harvard T.H. Chan School of Public Health. Next, I'll turn to Aram Guyesine, a social scientist, a social economist by training. Aram is passionate about social action, and she's convinced that each person must embody the change they want in society. She's specialized in program management, monitoring and evaluation, and research. So you see, she has a broad, a breadth of experience on regional research and accountability programs in West and Central Africa at the Mixed Migration Center of the Danish Refugee Council and the International Organization for Migration. At Social Change Factory, a center for citizen leadership, social innovation, and research, which she co-founded in 2014, she serves as the executive director. And then next I'll turn to Foyeke Oyedokun Adebago. Sorry, I hope I got that. Is a social behavior change program manager with USAID Nigeria. Foyeke has over a decade of progressive experience in the design and management of public health programs and currently manages USAID Nigeria buy-in into 2 SBC awards, Breakthrough Action and Research. With a flair for mass and media communications, Foyeke obtained a postgraduate diploma in TV journalism and served as an anchor for youth and women programs, as well as a reporter and newscaster for a private Nigerian television station for 2 years. Foyeke holds a bachelor's degree in human physiology, a master's in public health, and another in business administration. So now that I've just introduced our distinguished panelists, we'll move to the questions, but first I wanted to let you know that we have some prepared questions for the panel discussion, but we'd like to invite all of you to submit your questions using the Q&A feature, and we'll try to return to your questions as time permits. But please do share your questions. If we can, we'll introduce them to the panelists today and ask them to discuss them, but if not, they can certainly serve for future rich discussions. So now let me turn to our panelists. I'd like to begin by asking each of you, why is addressing equity and the social determinants of health so important in SBC programming focused on family planning and reproductive health? I don't. Beverly, were you responding?
Okay, I can take a first stab at it. Well, we do know that studies show that 80% of any population's health is created outside of clinics or hospitals. And of this 80%, 30% is attributable to behavior change, and the remaining 50% is a combined effect of other factors, social and environmental determinants, as mentioned a while ago. So behavior change, we also know, is a result of individual and social factors, both policy as well as social constructs. That said, this applies not just to FP and RH, but also other health areas. So in SBC programming, our goal is to foster sustained adoption of behavior and ultimately, of course, better health. By not addressing social determinants of health and equity, we are unfairly asking the individual to take the burden of doing or not doing a certain behavior. And perhaps from a programmatic investment standpoint, that may actually be unwise. It's actually betting on an individual who we're setting up to fail because we're not actually working on the systems around him or her to reinforce behavior change. And particularly, this is very critical for FP and RH, where the quality and sensitivity of the services are really not ubiquitous, nor as easily found everywhere. And social constructs, religious constructs are all going to be huge factors in individual behavior.
Aram or Foyeke, please go ahead.
Je vais y aller. Je suis absolument d'accord par ce qui a été dit. Pour moi, c'est même pas juste important, c'est indispensable de prendre en compte les déterminants sociaux à la santé et surtout l'équité, parce qu'on a beaucoup d'inégalités en termes d'accès aux informations de qualité sur la santé de la reproduction et la planification familiale, et également sur les méthodes qui existent. Également l'accès aux services. Sur ça, il faut un travail par rapport à l'équité de l'accès aux services. Et pour moi, en fait, dans le développement d'une stratégie, il faut prendre en compte tous ces aspects, sinon il y a de fortes chances d'avoir des échecs. Donc, dans tout ça, il est vraiment important d'aborder ces questions d'équité, d'accès à l'information, d'accès à des services dans la programmation et surtout au niveau des déterminants sociaux de la santé.
Thank you. I will just build on the contributions by Aram and Beverly. So first of all, I think it's very important to note that something that's a well-established fact is that access to family planning services and products is quite essential to improving the health and well-being of any given population because of its close links with reducing maternal and child health, morbidity, and mortality. And we also know, as panelists have highlighted, that from over 2 decades of experience and more, that a wide range of factors, including cognitive, emotional, social, structural factors, are associated with family planning behaviors. So whether it's to, continued use of modern contraceptives or intention to use, these are not decisions or behaviors that are practiced in, isolation just because an individual would like to. There's several factors. So I'll take an illustrative example. When we analyzed the Nigerian Demographic Health Survey of 2018 and some recently funded behavioral sentinel surveys in selected states in Nigeria, we found that in addition to the influence of knowledge, perceived norms, and social support, women with secondary education or higher were 4.5 times more likely to be current users of modern contraceptives than counterpart women who had no education. And we found similar trends for women in higher wealth quantiles than lower wealth quantiles. So I think what the statistics tell us is a story of unfair and unequal, sort of unjust systematic differences in the health status of different population groups, just by virtue of unequal distribution of social and economic resources and conditions and opportunities. And these conditions in turn then inhibit or enhance the capacity or ability of individuals to be able to responsibly determine if, when, and how many children they'd like to have. So for family planning SBC programs, addressing equity is, somewhat mandatory or some sort of a no-brainer, because otherwise in the design and implementation of that program, you would not be intentionally creating opportunities that align the benefits of that program to the needs of this population group. So if we must attain the targets in the SDGs, which calls for countries to, provide universal access to sexual and reproductive health services, addressing equity and social determinants of health is something that has to be part of, a broader considerations for SBC programs for FP. Over.
Thank you so much. I think that this was, the three of you have very clearly articulated the importance of the social determinants of health. And yet, as we all know from our own experience, from the research and so forth, that too often programs overlook that, or they underemphasize it, focusing more on the individual. So my next question is, we understand this. What could civil society, governments, and donors do to support increased attention to equity and to the social determinants of health, which, as you've alluded to, the panelists have alluded to, include education, income or access to resources, access to health services, and then other social determinants like migration status, gender, and so forth. So what could the civil society, governments, and donors do to support increased attention to equity and social determinants of health in social and behavior change programming to reduce inequities in family planning, reproductive health, and other health areas? And then as you're answering this, if you could also talk about what your specific role in advocating for such attention on equity and the social determinants of health in social behavior programming has focused on in family planning and reproductive health. I'll turn it over to the panelists. Maybe Aram, would you like to be first this time?
Oui, oui. Donc, pour moi, ce qui est vraiment crucial, c'est d'écouter les besoins des cibles afin de pouvoir y répondre. Pour ne pas, par exemple, donner à manger à quelqu'un qui a soif. Par exemple, selon une étude de l'ISF et de l'UNICEF, une enquête démographique et de santé, au Sénégal, 32% des femmes mariées disent qu'elles préfèrent attendre 2 ans ou plus avant leur prochaine grossesse. Mais elles n'utilisent pas de méthode de planification familiale. Pour moi, donc, il faut essayer de chercher à comprendre pourquoi elles n'utilisent pas de méthode de planification familiale, quels sont les blocages, vu qu'elles identifient ça comme un besoin, c'est un souhait pour elles, donc si elles ne le font pas, c'est qu'il y a quelque part, il y a quelque chose qui bloque, et d'aller chercher des solutions qui vont permettre à ces femmes d'avoir accès à l'information, aux méthodes et d'avoir accès également à des méthodes de planification familiale. Donc, pour moi, c'est vraiment la recherche et le fait de donner la parole aux cibles pour qu'elles puissent identifier leurs besoins et qu'ensemble, que ce soit la société civile, les gouvernements ou les donateurs, qu'ils puissent avoir une synergie pour travailler à apporter des solutions aux besoins spécifiques des cibles. Par rapport au rôle que nous, on joue en tant qu'organisation de la société civile, c'est vraiment de la recherche. On fait beaucoup de recherches pour pouvoir donner la parole à nos bénéficiaires, également identifier les besoins ensemble, également des groupes de discussion. Et les résultats de ça permettent d'orienter notre programmation, également de donner des informations aux partenaires au développement par rapport aux besoins identifiés et également des campagnes de communication pour le changement. Dans les régions ciblées, essayez de voir les personnes influentes ou en tout cas les dignitaires, que ce soit toutes les parties prenantes, les personnels de santé, les chefs des villages ou des communautés, pour vraiment mener des communications ciblées afin que les messages soient compris et que les besoins puissent être réglés.
Thank you. Oyeke?
Yeah, thank you. So I think to build on Aram's points, there are quite a number of critical roles that stakeholders can play. And I would maybe highlight a few that I think donors in particular can play. So I think the first thing donor investments might need to do is to go beyond seeing SBC programs as just for community mobilization and demand creation, because while these are very critical elements of SBC programming, expanding investment portfolios to acknowledge other aspects of FPSBC programming, such as social norms, like we've talked about, improving, client-provider interactions, and addressing some of the structural barriers that we've mentioned, will be very critical in really just making sure that we have a comprehensive, robust approach to dealing with access to family planning information, products, and services. I think secondly, in resource constrained settings, for example, in Nigeria, there are just so many competing health priorities. And then there are shocks that we have to deal with, like the COVID-19 pandemic. And then there are other sectoral priorities as well. And all of this remain largely underfunded. So I think civil society donors do have a role to play in advancing discussion around prioritizing systems approaches that are designed to shift some of the interconnected aspects of public health problems. So for example, actions that advance health literacy, especially for women and girls, and enable them to be able to find, understand, and use health information will have far-reaching positive implications for an array of maternal and child health outcomes, including family planning. So another would be efforts to promote social cohesion. So where communities are empowered, to bring their own local assets to the table and be active participants in finding solutions, like Aram says, specific solutions to the needs, of that particular population or subpopulation. Gender mainstreaming, inclusive development are also, things that could potentially be levers that can be pulled that have far-reaching effects in addressing equity and social determinants of health. So I think donors can provide the evidence. We can ensure access to data to countries and governments, and help to shape agendas, policies, and programs that identify these levers and are able to prioritize them in programming. So that way we minimize the effect of inequality and social determinants of health. Over.
Carol, I just go ahead.
Yes, please. Yes.
Yeah, I do agree with my co-panelist. Personally, I do think that the challenge now for development partners or donors is to perhaps be able to normalize addressing SDOH or social determinants of health reflected in theories of change or M&E frameworks of the projects they are approving, or even criteria for approving projects, right? We do know that now the tendency is you want to count what can be easily delivered by the projects, and often addressing the SDH part is going to be the more nebulous, no? Or you probably won't have sufficient output during that short span of time that you're addressing the project. But it takes time, and if we all need to do our part in normalizing it, then the development partner funded projects have to take that into account. Another thing that might be done is for us to foster multidisciplinary teams, no, of SBC specialists and perhaps technical experts for service provision. Oftentimes, as in our case in the Ministry of Health, my other bureau, Health Promotion Bureau, is made up of mostly SBC specialists, and the other bureau on disease prevention and control are really technical specialists on how to do the service provision, etc. Both have different competencies, but more often than not, both will fail to even address the SDH aspects, no? Because they're so into their own specialties. And there might be some room for them to collaborate in a more meaningful manner, be it in government projects or donor projects, but clearly there might be some space for that to grow. I guess I'll stop there and talk about it more later.
Okay, thank you. Thank you. Those were all very insightful. Thank you for those responses. So now let's turn to a question. We've talked about the role of civil society and also briefly mentioned governments and donors in supporting the attention to equity. But now we'd like to turn to the question of how might governments and funders use their power to ensure that the initiatives and organizations they fund and support would systematically and intentionally address equity in their SBC work. That's and also that in SBC work that's guided by community needs and values. Foyeke, I'll turn to you.
Okay, thank you very much. I think I love the word power in that question, and I'll play on it a little in my response. So I think we generally might agree that donors typically wield a lot of power, right? It is often said that he who plays the piper will dictate the tune. So like donors who bring money to the table will typically have a big voice in decision making and sort of shaping up the agenda. However, so I think that donors can definitely deploy that convening power to sort of muster some sort of consensus building from the ground up that co-create some of this, solutions and investment agendas with communities, governments, such that we're looking at investment agendas that are very context appropriate, that do not just focus on programming, but have an equal focus on research and ultimately increase attention to the social determinants of health, especially among and across certain subpopulations for which we already know that there's a really big power imbalance, with that plays into how they access information and services. I think donors can also, like Beverly started to talk about, prioritize funding for interventions that address structural and intermediary barrier determinants, in addition to the individual, social, cognitive, and emotional. In particular, we could begin to think about multi-sectoral programs for FPI-rich investments that recognize this social determinants of health, that prioritizes them, and provides solutions to addressing them. So in Nigeria, USAID awarded an adolescent family planning program that tried to look at the linkages between vocational and livelihood support, substance abuse, gender-based violence, which were critical determinants of the choices that adolescents were making in terms of their reproductive health and family planning choices. So those kinds of programs that find those linkages and explore the deeper roots of inequity and develop solutions that connect FP to other sectors, I think are critical. Finally, there are high impact practices that have been documented as resources and research over extensive years of research. So we know in FP SBC programs, which practices are best practices, which ones are emerging, which ones are promising. So I think we can also be very intentional, both as donors and implementers, to support and devote resources to the implementation of those practices within contexts where they are appropriate, but also the monitoring and evaluation of the same. Over.
Thank you. Aram, could you respond now?
Oui, merci. Je pense qu'il faudrait mettre en place une approche systémique dans le but de permettre cela et que cela serait la condition pour l'obtention de financement et de soutien, avec la mise en place, bien entendu, d'un suivi et d'évaluation. Il faudrait identifier les pratiques et les attitudes à instaurer au sein des organisations qui vont permettre justement de prendre en compte tout ce qui est le changement par le comportement social et également l'équité et les besoins et valeurs de la communauté. Mettre en place justement cette approche systémique pourrait aider les organisations à prendre ces questions en charge, pourrait fournir également aux parties prenantes des informations claires, concises et cohérentes pour justement l'intégration de ces questions dans leur stratégie et politique. Et également, il faudrait reconnaître et valoriser les organisations qui, eux, justement, ont intégré cela, tout ce qui est équité, tout ce qui est transformation par le changement social dans leur travail et également faire des renforcements de capacité auprès des organisations qui ne l'ont pas encore intégré, mais qui ont cette volonté. Et pour moi, si tout ça est en place et que les financements sont conditionnés par rapport à cela, cela permettra justement de pouvoir intégrer cela de manière systémique dans les programmations, dans le travail, et ça va vraiment impacter la vie des communautés.
Thank you. Beverly, would you like to add to that?
Yeah, maybe just a little bit. I was wondering, and this is something that we also haven't done yet in the country, but it's not, I think it's okay to dream, right? If you're talking about governments ensuring that we are systematically addressing SDH in our work, what is the possibility of, say, national planning ministries making sure that certain indicators are really shared across sectors? So for example, if we really do want to make sure that, for example, our healthy schools portfolio, which is lodged within the education ministry, will get the same buy-in, not just in words, but actually in resources and action, then we actually should be sharing that indicator, right? Because for now, all the health indicators for FP and RH are really just lodged within the health ministry. So any body that we will be having, like a multi-sectoral body for this particular initiative, it's all, and maybe not all, no, but it could all just be lip service for the other sectors, as long as it's not part of their clear deliverable. So I guess there has to be some mechanisms for us to advance in that front.
Thank you. So I think, as we're discussing the social determinants of health, we recognize these are structural factors. These are factors that will require long-term co-funded. You've talked about the importance of funding, of course. So it will require long-term co-funded and multi-sectoral partnerships if we are going to effectively address the social determinants of family planning and reproductive health and the existing inequities. So my question for the three of you is, how feasible is that? How possible is that? Aram, could you begin by responding?
Pour moi, les partenariats seraient à différentes échelles. On doit avoir des politiques publiques qui sont portées par les gouvernements et qui vont prendre en compte les inégalités sociales de santé. Pour moi, c'est vraiment à ce niveau-là qu'on peut avoir un changement structurel et que cette prise en compte soit vraiment généralisée au niveau des pays. On peut aussi avoir des partenariats qui sont entre les donateurs et les gouvernements et les organisations. Et ces partenariats qui seraient un peu dans la ligne de ce que j'ai dit, vu que les donateurs et les gouvernements ont du pouvoir, ils peuvent justement influencer les activités des organisations en les incitant justement à prendre en compte tous ces aspects pour pouvoir avoir un meilleur impact sur les cibles et également voir les partenariats au niveau même des cibles, savoir toutes les parties prenantes qui doivent être engagées justement pour pouvoir aborder cette question à la source et voir comment y apporter des solutions pour réduire les inégalités qui existent de fait, pour lesquelles on ne peut... Ça dépend de sa naissance, d'où on vient, d'où on habite, mais essayer d'apporter des solutions par rapport à ça en répondant aux besoins.
Thank you. Fueke?
Thank you. So I think I'm optimistic that many programs across sectors can support some of the common denominators, which is typically associated with system strengthening. So I think, like Beverly was saying, we need to have shared vision, shared outcomes, and sort of consider that outcomes are sort of shared and people across sectors, there's some responsibility for health outcomes. However, the common denominators around system strengthening, for example, can be contributed to by several ministries and agencies and sort of across sectors. And investments in some of these common denominators like community and local government capacity strengthening systems, would pay off across sectors inherently over time, right? So technical area funding parameters would always continue to exist, but, we could look across the denominators and those things, the tools, the research, the connections between issues, the levers that connect all of these issues together, especially for these subpopulation groups that create those barriers and inequitable access compared to other populations, and that those kinds of capacity strengthening and co-investments in this common systems areas could have long-lasting effects that ultimately support better outcomes across sectors, so whether it's education, livelihoods, health, family planning, infrastructure. So I just wanted to add that thought. Over.
Thank you. Beverly, would you like to add something?
I think it's really possible, but perhaps to lower the risk for such projects, we can look at smaller geographies, maybe not national level projects, sub-regional or even smaller contexts. But then perhaps the most important part here would be what is the institutional base, no? That is doing the conducting of the project. So for example, in the Philippines, I can see that it can be probably implemented in a certain locality, but then because we are a devolved setup, every 3 years your mayors would change. No? So the local leadership changes. So maybe this is actually possible if it's situated in a local NGO, no? Probably not an NGO from the capital who flies into the area just to do a project, but someone that's more rooted in the area, or perhaps an academic institution that's based in the area. So there are mechanisms maybe to increase the success rate and lower the risk of such long-term co-funded multi-sectoral projects, but we probably need to see that this should be made possible.
Thank you. So we've talked about the importance of partnerships. So how best might we, as the SBC community, advocate for more attention to equity and the social determinants of health in SBC programming that's focused on family planning and reproductive health? Beverly?
I think the best way that we can advocate is to have more examples, more concrete examples that it can actually be done, and that it's not a theoretical aspiration to just address the web, no, of wicked problems. Second is really to make sure that we are all speaking the same language. What I've experienced is that in my country, the understanding of SBC or health promotion is often reduced to, oh, the people who develop materials or collaterals, no? And it's only recently that you're trying to get people to appreciate that, wait, there's a science to this collateral, but more importantly, we actually have this entire SDH framework that we're looking at and that we want to implement alongside these more flashy products. So maybe just those two things, critical, very, very critical, even among already champions who are speaking to each other.
Thank you. Foyeke?
Thank you. So I think Beverly definitely touched on very critical points. I agree that we need more examples, maybe a smaller pilots that sort of serve as proof of concept, and it then becomes easy to sell that, the possibility of having such a multi-sectoral, partnership that drives outcomes across several sectors for the benefit of health and family planning. I think, we know that and agree that many of the drivers are sort of outside of the health sector. So in thinking through multi-sectoral partnerships, I think one of the things we want to be intentional about in the how is to think about the non-traditional sectors that could also bring value to the table. So I know we typically would look towards education and livelihood support, but perhaps housing, justice, environment, and not just other sectors, can also play critical roles in giving everyone a fair chance, because that's really what the social determinants and equity is about, is that fair and just chance to be healthy, fair chance to be able to access health information without, crossing additional barriers simply because of your socioeconomic status, or because of your identity, your sexual identity and things like that. So I think we can't think outside of the box in the how, and in making the advocacy and the case to think about other sectors, more voices that could potentially help with advancing this. And I think one additional point to add is that multi-sectoral partnerships require time, require a lot of investment in coordination. So I think Beverly talked about this briefly earlier. We need to think about donors in particular need to be patient enough to recognize that this takes a process. And in addition to the outcomes that we typically want to measure, think about where the opportunities are to document the processes that result in those partnerships, the lessons, and be very intentional in the flexibility of their words to be able to take into account some of these outcomes around the partnership itself, and invest in strengthening the capacity of local systems to coordinate those partnerships so that they can outlive those examples that we're creating. So I think there are very interesting ways we can do this and be more effective at advocating for equal attention to equity and SDOH. Over.
Aram, is there anything you would like to add?
Oui, rapidement, je suis parfaitement d'accord par rapport aux propositions des autres panélistes. Juste dans le fait de plaider, pour moi, on doit plaider à plusieurs niveaux avec des interlocuteurs différents et que l'approche à chaque fois doit s'adapter par rapport à nos interlocuteurs. Donc, pour ça aussi, la recherche aide beaucoup. L'identification également des besoins et des contextes sociaux et culturels est importante. Et ce que je rajouterais juste, c'est qu'il faudrait essayer de plaider pour que la planification familiale soit incorporée dans les stratégies nationales et de budget, et voir comment inciter en tout cas les gouvernements à avoir une approche multisectorielle pour que ce soit vraiment un élément clé dans tous les programmes de développement. Merci.
Thank you. We have some questions. Now we'll be able to turn to some questions from those of you who are participants in the webinar. And one of the questions I noticed that you've already alluded to, one of the questions is about the fact that the poor health of people living in poverty reflects the social gradient in health within countries. And there are marked health inequities between countries caused by the unequal global distribution of power, income, goods, and services. So is there anything more any of you could add about how the S in SBC could be addressed more broadly, thinking about these inequitable distribution within countries or between countries? Anyone on the panel?
Yes, I could. I think we alluded to quite a number of ways we could possibly do this as part of the panel discussion. But I think one additional thing that just comes to mind is, just thinking through design approaches in itself. So I think we typically have started more recently to embrace human-centered design and other kinds of design approaches that help us to ground programs in the lives and the realities of the beneficiaries. I think those expanding those investments in those kinds of approaches and being patient with the process can be really beneficial in the long term to addressing equity, because the drivers and the barriers sometimes are not, even within the same state, for example, in Nigeria, could vary from one, culture to another, just because of the overlaying kind of norms and other gender practices that could add an additional layer of hurdle for certain populations. So I think being a lot intentional about audience segmentation, about design approaches could really be very important ways to do this. Over.
Would Aram or Beverly, would you like to add anything? I know that you've already alluded to or even spoken directly to this question. So I'll just ask, we have time for one more question. And whoops, there was a question about, given that the social part, the S in the SBC, has been underemphasized in many settings in SBC programming, does it make sense to focus explicitly on the social, the S in SBC, and give more attention to it? What do you think about that? Any of the panelists, please feel free to respond.
Maybe I'll take a stab at it. I think it really depends on what your program objectives are. If we are situated in the health sector, our pathway for better health outcomes is partly, or largely behavior change. And so in order to get the behavior change going, then we have to do the S. I guess it really just depends on what lens you're looking at, because if you want to address really just the S, then you can probably be you're in education sector, you're doing economic work. But I guess it's a question of what lens are you taking and what is your accountability in this entire development process. So I guess no right or wrong answer there.
Anyone else, Aram or Foike?
No, I completely agree. I think it depends on where you're looking at things from, and you could find benefits in, poverty, sort of alleviation programs, or sort of programs that try to provide social protection for less advantaged groups. And you could focus on that, but ultimately the health sector and other education sector would benefit from those improved conditions of living and livelihoods that those programs. So I think it depends on who's funding and where sort of like Beverly says the accountability is and what your interests are. But focusing on just the S is not a bad idea if we could connect the dots in terms of just making sure that other sectors are able to leverage the gains from those programs for health outcomes as well. Over.
Wonderful. Thank you all. This has been a very rich discussion. I think that we've all learned a lot from it. And we'll go ahead and I think we'll turn over we'll turn now to the next webinars. We have 2 more webinars forthcoming. The next webinar will be how can SBC programming address equity and social determinants of health considerations in FPRH. It will be Tuesday, April 26th, from 9 to 10 a.m. Eastern time. We hope you'll all join us. And then the third webinar is what does it mean to prioritize social accountability in SBC programming to address equity and social determinants of health and family planning and reproductive health. And that's Wednesday, May 23rd from 9 to 10 a.m. That's obviously not right. We're already here at March 23rd. So I hope that you'll all join us for the next 2 webinars. And please feel free to reach out to any of us if you have any comments or suggestions or questions. This was a wonderful group of panelists, and I'd just like to thank you so much for your participation. And I'd also like to thank all of you in the audience for your questions and your interest and commitment to enhancing and prioritizing the S in the SBC. Thank you all.